Perfect. Can you hear us?
Hi, yes, I can.
Okay, cool. And we are recording. I think it automatically records, but I'm gonna check. Yep, we're recording.
All right, perfect. I did just go ahead and forward this to my colleague Mary in case you see her show up in the waiting room. She is a clinical educator here. Well, she was a clinical educator here at AvaSure for many years, but she's recently joined us as a customer success advisor. Oh, here she comes. So she's just going to listen in today. She's going to be the same role as I, just in another region. So she's just doing some orientation today with me. All right. Now, should I wait in case anybody virtually joins this meeting?
No, I would just go now because I think since we flip-flopped, they're probably gonna be confused.
Yeah.
I'll probably just say, I'll just wait for the recording.
Okay. That sounds good. All right, I'm going to go ahead and get my screen shared and we'll get started. Now, I will tell you, once I share this as a slideshow, I won't be able to see, well, I can't really see your faces anyhow, but if you raised your hand or anything, I won't be able to see anything on the screen. So this presentation, very laid back, jump right in, interrupt me. I love having dialogue back and forth with this. I think that's how it's the most beneficial. So you guys just feel free to jump right in if you have a question or a comment. Just to introduce myself to everybody that's in the room, I'm Lindsay DeBernardi. I'm a customer success advisor here at AvaSure. I'm a nurse by background myself, and I meet regularly with Jimmy to talk about the AvaSure program. And really our goal of our meetings and our calls are to ensure that all of the sites have successful outcomes so that you're meeting your goals, that you're using the program to the highest potential that you possibly can. We help with training, onboarding new hires, doing a lot with data and data management, offering training resources and classes like today. And so I think on our meetings, we kind of identified that it's been a little bit since we've either been on site or provided some refresher education for the VSA team. So that's really the intent today, to go ahead and do this. So we actually created this PowerPoint presentation a few years back for the monitor techs, which we're actually calling VSAs now because it's evolved more than just a monitor tech position. For you that have been doing monitoring now for some time, just to ensure that we're elevating you guys and really empowering you to work at the highest level you possibly can. And so this is for those of you who have been doing the monitoring. It's not going to be like the training you got when you were brand new or when you just go live. It's on a little bit more of a higher thinking level here. So with that, I'm going to start the slideshow. Okay. Can everybody see that okay?
Yep.
All right. This is kind of some of the agenda items that we'll talk about today, really talking about how we know communication is key, device troubleshooting of the program, how to go ahead and get help if you need it. Really going to highlight documentation. So how to properly document and also the benefit of documenting on the intervention log as well as in the adverse event log. And I know back when, for many of our customers who have been live on this for quite some time may have started out not using the documentation piece of it. So that's really why we've rolled this in. A lot of people are going paperless now and are really encouraging you to do some documentation. So we'll talk about that. I'll give you some new VSA best practices that we have recently outlined, and we do have data to support the statements that I'll say today as well. So we'll review all of that. Critical components of patient monitoring. You know, when we first came out, we thought this was just a device, we'd plug it in. It's for visual, we're just going to prevent patients from falling, and that's kind of what we did, but it has evolved. And we're able to communicate with increased technology with a lot more people within the organization. And so this visual here shows gears. And if you can imagine, if we pushed play, these gears would be spinning, right? And it wouldn't work without one person's input. So these are the critical components of patient monitoring. We call this the feedback loop. It involves the VSAs, the floor staff, and the patients and family all communicating together. And it's really a necessary component to keep these patients safest and to have effective virtual monitoring. So what keeps the gears turning? I kind of mentioned it already. Number one piece of this program is communication. It is a key to a successful program, not just communication initially, right? So a lot of times you're good at getting that initiation form filled out and the information from the nurses, but continued communication between the floor staff and you guys is really, really an essential component for effective safety monitoring. And with patients and families. So we do have increased patient satisfaction scores and increased nurse satisfaction scores when we hear the VSA is actually communicating with the patients and with the family members who come in as well. I'm going to play a little video. Some of you that have been here for a while may have seen this. It's the monkey business illusion.
You missed the gorilla.
I did. I'm trying to look at them all. I'll look at them. Oh, okay. I don't know how I missed that the first time.
All right, I'm going to pause there because I did hear some laughter and I will fully admit I missed everything the first time I watched this. I missed the gorilla. I didn't see the curtain change colors, didn't see anybody leaving, and I think I only counted like 12 passes. So I hope that was really helpful. You know, that is why it is key to receive as much information as we can about a particular patient, because you can see what our minds do when we're focused on one particular thing. Also, as a VSA, let's say you get a form that says, you know, we're just watching for elopement. You guys know if you see something else, you know, it's your responsibility. You notice it appears that a nurse is at risk for some sort of violent behavior or aggression from the patient, right? Or you notice a visitor acting very suspicious and slipping the patient something. Yes, we're monitoring for falls or elopement, but we have to have our eyes and ears open for so many other things in that room while we're monitoring. So keep that in mind. That's really the intent of that. One of the key things here, which is the next slide, and I think it's a really great slide post that video, is to always wear your headset. This comes as a complaint sometimes. This is also something when we go on site and do some rounding and observing, we'll see these headsets down around people's necks sometimes, but it really is best practice to always wear your headset. That way you can be ready to redirect patients for increased safety. Remember, you can only hear into one room at a time. And so it's really essential and important that you're clicking into those patients' rooms so you can actually listen in very quickly. The expectation is for monitor staff to be proactive versus reactive. And so if you're seeing that sound go up and down and fluctuating in a patient's room, you got to have your headset on very quickly so you can click into that room and hear what's happening in that room if you see that sound indicator going up and down. There are, if you guys had some feedback on that, there are different kinds of headsets. There are ear covers. Some sites, have multiple that they can switch in and out so you can clean them. But we do have things we can talk about. So if this is a challenge for you guys or you have a rationale for it, please bring that to your manager and we can kind of talk about options for headsets. Best practice alerts. Using your voice instead of pre-recorded prompts do show in our analytics, and we do have years and years worth of analytics to support this statement, that we see better outcomes from patients with a 70% verbal redirection, so meaning you're pressing that microphone and using your own voice, to a 30% pre-recorded prompt. And we do show that patients do respond better to an actual human being's voice versus those very loud pre-recorded prompts that can be a little more confusing for many of the patients that you monitor. Now, with that, I won't say many. There is a certain patient population that may respond better to those pre-recorded announcements, and you guys are probably the experts at identifying who those people are, and that would be absolutely appropriate. There's other reasons why pre-recorded prompts can be used, and I'll talk about that here on the next slide, but just highlighting verbal interventions creates a personal touch, creates a better relationship with the patient's families. Also, the nurses and the nursing staff at the bedside actually hear you communicating with the patients and families, and it's more an inclusive part of the care team. You're a human being, you're an actual employee of Union Hospital, right? You're not employed by AvaSure, you're employees of the hospital, and you're part of the care team just as much as the CNAs or the PCTs on the floor are. So when those nurses actually hear you, that's going to help them have trust and buy-in with the program, know that you're attentive, and they hear and see the work that you guys are doing. So increase trust throughout patients and families with the use of those verbal interventions as well. And here are some of the reasons why you would maybe use a pre-recorded announcement, however. So if you needed to change the gender, you have a male who will only respond to a male, right? And you're a female doing the monitoring, so you're going to use those pre-recorded announcements because this gentleman will only reply to a male. Language barriers. So we should never really be hearing on the floors that they can't use a device because the patient speaks Spanish. We can fire all those pre-recorded announcements in 30+ languages. So please keep that in mind, and that would be a benefit for using those. Also, these are really beneficial for multitasking. You may or may not know this, but if I'm talking into a room and Jimmy's getting out of bed and I see the patient next door in another room starting to get out of bed as well, but I'm not done redirecting, I can hit a pre-recorded prompt while I'm communicating. So it can be used as a multitasker. Or you're on a phone call and you want to finish that phone call, so you hit a pre-recorded announcement very quickly. So definitely some benefits for those as well. Just please consider best practice to use your actual voice first. And we do have results to support that, that 70% to 30% is valid.
I do have a question on that.
Yes, please.
I had a patient the other day that they only spoke Arabic.
Mm-hmm.
Now, the only languages I had available to use were Spanish, Chinese, and then I think Simplified Chinese, or Mandarin.
Yeah.
Or something. Did they add a bunch of languages?
So super great question. It depends on your contract and the subscription model that you have. So it sounds like you guys have 4 languages that come with the software. You can add them a la carte. And this, of course, would have to go through your leadership. And we can always get a quote for that. Or if you go to our full subscription enterprise, all of them come with it. So there's a little bit more of a business perspective on how many languages you get. But if you have, you know, a very high Arabic speaking population and you're using that frequently, maybe we could look at adding 1 language instead of the entire package. So Jimmy, that's something we can talk about.
We don't run into it very often,
Yeah,
but it was just something, you know.
yeah.
We have run into it.
Lindsay, so outside of those 4 that we have, what do you think the next most used is? Like in the Midwest?
It varies on location.
Probably a lot of Arabic though, I bet.
I mean, over my time of working at Union, I feel like that is probably the next big one I see.
Yeah.
Yeah.
Okay.
So I'll what I'll do, Jimmy, just so you have it proactively, I'll send you the list of languages that we have. Maybe you guys can kind of take a peek at it and start looking at it.
Perfect, thank you.
Okay. Yeah, great question. Great catches. I don't know, do you guys at your site have like a whiteboard or a kudos board or a great catch log where you document and take credit for all of your good catches?
No, sadly.
No, we have a cork board that we don't really use for much, so we could turn it into that.
Yeah, just always like to mention this because great catches really can show improved utilization as you share those great catches. It enhances confidence in the program. And most importantly, why I like great catches is it affirms the value of your role in your position. So you guys are like these unsung heroes, right? Your eyes are in these patients' rooms 24/7, more than any physician, nurse practitioner, PCT. You know these patients, right? But you fly under the radar because your little faces aren't seen all the time. You're behind this device, people don't see you. Sometimes it may feel like, you know, your position is undervalued. And so I really encourage you guys to maybe look at documenting great catches, or perhaps some people have a whiteboard or a cork board, like you said, where they'll have a good catch and they'll plop it up on the board. And then once a month, the manager picks like a great catch of the month and they share that to the whole hospital. All of the care units hear about it. Some people will put it in a little newsletter with a face of who the VSA was. So they're actually putting a face to a name. Just really, really validates the work that you guys are doing. So a couple of things. Take credit for them. Whether you feel like it's a good catcher or not, you do not know that by me just saying, hey, have a seat in your bed, let me grab your nurse first. That patient may not have even had a one-to-one sitter in their room. They would have had nobody. They could have stood up and it could have been a little 80-year-old who fell and broke their hip. And we in the clinical world know if an 80-year-old breaks their hip, it can be very dark path ahead, right? So we don't know if they would have fallen. And I know you feel like you're just doing your job. Don't be humble in those situations. Take credit for those. And really, that's that proof in the pudding. Those are those things that we want to blast out and share to the rest of the hospital. That's why you have this program. And those great catches are a really good thing to have. So we do have a log that we can send. It's a paper log, though, that we'll send out and have you take credit for those great catches. But I really love Great Catch of the Month. There's some hospitals that'll actually have a baseball and they literally, toss it and give it to somebody who had the greatest catch every month, or a traveling trophy for a great catch of the month, something like that. But to the unit that had it, and then the monitor tech gets highlighted as well. But really encourage being creative and talking about these great catches, sharing them with others. Even if it doesn't feel like, you did anything too big of a deal, you really did. Importance of data entry. So just always like to mention, when you log in, it is very, very important that you log in under yourself. not a generic login. And I'm going to show you in a little bit, some of you might not be exposed to the data that is available from the program, but you know, every login, every logout, every click, every intervention, every stat alarm, every admission, discharge reason, any of the notes that you change, we can see that, not we, but your leaders can see this in data export. And it's not necessarily to be punitive, but it's to help you too. So great catches, all the good things you've done, all of the times you've intervened with patients. When you have feedback from a nurse saying, well, they didn't do anything, right? We can look and see, you know, we can show that, yes, you guys did. You pressed a stat, you pressed a verbal intervention, but the stat alarm went off for 60 seconds, which is way too long, right? So you want to be under yourself when you're actually doing your monitoring. And you also want to not be under yourself when you're out at break. Whomever is covering you for that break, I know even if it's just 15 minutes, you're running to the restroom, you really should be logged in under yourself. Any questions on that?
You guys currently log in?
I do, yeah. You have a login, right?
Yeah.
Okay.
Great. Good job. All right, this is a picture of an AvaSure dashboard. Your manager does have access to see this, and this is live. So this is a live 24-hour, and this is just fake data, of course, but Union, you know, if you were to log into your Union dashboard, you'd be able to see this as well. And this updates every 5 seconds, but it gives a snapshot of what the last 24 hours looked like at your hospital. So how many devices are in use, how many are available to use, how busy your patients on devices have been, how many stat alarms they've had, how many times you've talked into the room to the patients. And I have to put in a shameless plug. I mean, your manager will want to at least see 2 verbal interventions, which is that little purple circle over on the far right-hand side of the screens, right? Because we want you to introduce yourself to the patient. Hey, I'm Lindsay. You know, it's 7:30. I just got on. I'm going to be here till 7 p.m. tonight. If you hear me talking, I don't want to be confusing, but I'm here to keep you safe, whatever you want to say to them. But again, communication is key, and the nurses are also hearing you introduce yourself. And so we have access to, or your leadership has access to see, you know, where patients are located, what rooms they're on. This is really helpful for when you say, gosh, this patient is so busy, I cannot watch my other patients. They can peek at this and have supporting information and see, oh my gosh, yes, you've pressed 22 stat alarms in the last 24 hours. This patient probably isn't the best candidate for a device, or vice versa, right? You are monitoring a patient in 212, which is the patient on the bottom right corner, has been on for 3 days, no stat alarms, 4 verbal interventions. This program's working wonderful for them. You're redirecting them, they're responding, and you're not even having to press a stat alarm. But let's say you get a one-to-one sitter request for this patient and you're wondering why, right? Those are types of cases you can kind of pass on to Jimmy and just say, yeah, this patient was doing really well, but they wanted a one-to-one sitter. I'm not really sure why. So those are things that we're able to use this dashboard for. Admitting and discharging patients. So again, this is data entry. We want to ensure that you're very intentional about knowing what the patient's being monitored for. And the most important thing is empowering you that it's okay to ask clarifying questions to the nursing staff. There's a reason why you're asking, and truly the reason is only that you want to best take care of their patient and keep them safest. And you're only as good as the information that you receive from them. And so you really want to ask clarifying questions to ensure that we know all the reasons we're monitoring and that we make sure we get that primary reason from them as well. So when you add a patient to the device, you know, you get this box that pops up, which is this middle column there where it says add patient, and you're selecting your reasons for telesitting. You could click 4 of those. I don't know if everybody knows that, and I see this sometimes when I go on follow-up visits, that's to only click 1 of those boxes. You could actually, you know, click 3, 4, 5 of those under adverse events, under patient conditions, and under risk factors. But you then will have to select one primary. So there would be a drop down and you'd select what the primary was. So that is the information you do have to obtain from the nurse that's doing the admission, but you can monitor for multiple reasons. Clicking other can be a little bit problematic, and I'm going to show you on the next slide why it's a little bit hard when we're looking through the data and doing some tracking and trending for why we're admitting and discharging patients. It's necessary sometimes, right? Let's say you're monitoring for seizures. We don't have a good option in AvaSure for that. Let's say you're monitoring for eating disorders. We don't have a good option for that at this time either. So that would be really appropriate to put as other. But other kind of dirties up that data. Now your manager has to kind of figure out why this % of the population that we're monitoring is it being admitted, and does it really help you to know why they're being admitted. So something to keep in mind, you know, if a nurse puts other and writes confusion for a patient condition, it's okay for you guys to say to them, can you tell me a little bit more about why they're confused? Is it because they're on a substance, a medicine that's making them confused? Do they have a brain injury? Are they delirious or have some dementia? Maybe they have a UTI. And a UTI, infectious disease, can make a patient very confused. So maybe it's an infectious disease type issue. Do they have a history of a brain injury or a stroke? So usually there's a reason that's causing the confusion. Which would help you to better take care of the patient because you'll get more information out of the bedside staff. So if you can avoid the use of other, if possible, really, really encourage you to do that. If it fits into one of these categories, please try to select the category versus other, but others there if you needed to use it. Same? Yeah, go ahead.
Staff, even when we start asking questions, you know, okay, they call and they want you to watch them for getting out of bed. Okay, that's our primary thing we watch them for. But, you know, are they confused? Where's their IVs? Do they have a Foley? You know, we
Yep.
go down the whole list. I want to know if they have any other tubes at all. And they're still like, why do you need to know that? So I try to tell them, you know, the more information I have, the better. You can't have too much
Absolutely.
information. And then sometimes when they do tell us, but they don't tell us why, we'll go and look up the patient to see what happened. You know, if we can find something in the notes to add to what we've already got. Because, you know, if you're watching for them to get out of the bed, but they pull their IV out, then they're going to call you up and say, well, they pulled their IV out. You're not watching them.
Yep. Yep. You got it. You got it. So you know what you're doing is what you should be doing. And if that continues to be a problem with a specific floor or specific person, I'd escalate that to your leadership, right? Then a discussion can happen from a manager perspective. Because you're exactly right. That was what I was going to come back with. That if they lost that IV, you'll be the first one that would know, right? That
Yeah.
IV came out, but they didn't tell you that.
Sometimes
So
they're in a hurry, or they're setting up the camera for a different staff member. So they don't have all the information and they're like, well, why do you need to know all that? And I'm like, okay, I need all of this information. You can't go yet. I need more stuff.
yeah, yeah,
And usually, and sometimes they'll be like, well, just let me get that nurse. And that's okay.
Yep.
As long as I get the information.
you got it. You got it. Advocate for yourself, and ultimately, I mean, you can say to them, it will help me keep your patient safest.
Yes.
Right. This is information I need to know to keep your patient safe.
I do have one thing I wanted to ask. Is it possible for us to get more options like added? Because we do see, like recently, we've gotten quite a bit of patients where we end up having to watch family members for bringing in like illegal substances for the consume, for instance.
Yes.
And obviously we have to put some of it, you know, in other and stuff like that. Like, is there a way for us to like have our managers request like a certain thing be added or something, or?
That is a super great question. I love that you asked that. And I wish I had a better answer, but I don't, because the answer at this time is no, it's not
Okay.
a la carte. So everything that you see in your software is what the entire nation sees.
Okay,
So
I wasn't
if,
sure.
yeah, it's a super good question. In fact, I've put an idea into engineering to have this be what I would call a la carte, where customers can pick, what they want. Seems a lot easier than it really is from a technical and engineering perspective, I'm sure. Um, but we do value that information though, because when we do upgrades and updates to our software, it's these types of things for why things get added, right? It's your feedback. It would be much easier if we have this, and it speaks in numbers. So we do have a couple that we've asked to be entered: seizures and eating disorders for sure. We have asked for that before, but contraband is kind of what you're talking about, where they're bringing in drugs and illegal substances to be added, has been entered as well.
Okay.
So there is a possibility that things could get added, but it's not an easy task, and it'd have to speak in numbers because it would
course.
change for everybody. So it'd kind of have to be a very common request across the board. So we do watch the data for why customers pick other and what they're typing, so that we can add those once we see it on repeat for quite some time. Then they can add that as an option. So super good question. I wish it was easier where you could customize it, but you just can't. Not off the table. They will add things, but they'll add things that many of the customers, they're seeing the same requests or the same other reasons being entered. Same goes for discharge. So discharge reason, and I'll show you a little picture too about why that's important, but it's one of my favorite metrics, meaning piece of data to know for how we're doing with successful program and meeting our outcomes, and are we on track for that? And are we following our policy and our workflows? Discharge reason is really, really important to try to obtain if you can avoid other. So a lot of times they'll say, no longer needed, right? And so a lot of times VSAs will pick other and then type in what the nurse told them, because that's what they said, no longer needed, or doctor per doctor, right? But why? But why do they no longer need it? Or why did the physician discharge it? Is it because they're going home? Is it because their behavior's improved? Is it because they're getting a one-to-one? So again, asking those clarifying questions so you can get accurate data entry for the discharge, because the discharge reason is really, really important. So if they're leaving you hanging, it's okay to say, can you tell me a little bit more about why it's no longer needed? Couple little things that we see a lot: passed away, expired, is actually discharged from hospital in the medical records. So you guys could do discharge from hospital. Unless your manager wanted to track that, then that would be something you'd put as other. But typically that's discharged from hospital.
I do have one. For instance, it happens like a decent amount, but I wouldn't say it's like a crazy popular one. But they do get, like, when they get transferred to like ICU. What would you prefer us to put it as? Because I've heard different people say different things on it.
I love that question. Here's my recommendation for that. So think back to why you were monitoring that patient before they were going to the ICU. Okay. Were they impulsive, irritable, aggressive? Were they having respiratory distress, right? We were worried about them getting up. We didn't want them falling. Now they're intubated. Let's say they're getting sicker, right? You're watching them because their behaviors are aggressive, impulsive, they're confused, they're trying to get out of bed. So you're monitoring them. Now they've got this patient intubated, they have this patient on some pain meds and likely some sedation, and they're very calm in bed. Now they're going to the ICU now because they're on a vent and getting some extra support. They're sicker, their acuity level's higher, but their behaviors have actually improved that you were watching for, right? They were aggressive before, they were trying to get out of bed before, you were watching them for falling. And now they're nice, they're comfortable, they're calm, they're getting the support that they need. Their behavior is actually improved. And I know that seems a little bit bizarre, but the reason is if their behavior is improved, why wouldn't that device go with them? Right? How come they don't need that device anymore in the ICU? And many times ICUs are a little bit different because they might have their own video monitoring, or they're only, 1-to-2 ratios, one nurse per 2 patients. And so they can see their patients all the time. But likely their behavior is actually improved. Same with hospice or palliative care. You bet your bottom dollar we're going to do our best to probably keep them nice and calm and comfortable. So they're probably on some medicines, and what we were monitoring for has probably improved because we're keeping them nice and comfortable. So although they're sicker, they might actually be dying, their actually behavior's improved. So it's a little bit of a different way to think of it, but that's what most of our customers do in those types of situations. Now,
Okay.
the ones that keep it at other, it might be meaningful data to Jimmy. Maybe he really wants to track and trend how often that's happening, that they're going to another unit and not taking the device with them. We do have some managers that want to track that, and that's absolutely okay too. So again, it's a conversation to be had amongst your team on what data is important for tracking and trending. And if Jimmy wanted to know that, then you would pick other and you would put ICU. That way he could follow along how often that happens. So that's a really good question. We hear that a lot in the ED. They'll be on a monitor in an ED and then all of a sudden not on a monitor on the floor, but we don't really know why. The device didn't come with them, or they didn't get admitted to a device on the floor. And so again, asking those clarifying questions for why.
I would say we're pretty good on following up with if they're gonna, take a chemo with them or not. Usually we call up to like the unit and we ask clarifying questions on whether they're staying with them or not, and if they should continue to be monitored.
So good. Good work. And you've probably not seen this before, have you guys?
No.
Yeah, so this is our ORNA data. All of the work that you guys do goes into a database and gives your hospital averages on how what percent you're admitting for falls primarily, what percent you're admitting for medical device interference, what percent are we typing in other. We can even see what all the entries, that are written in for other, how often you're monitoring for elopement. We also are able to show your hospital comparisons to the national average, so we can see how you're doing in comparison to the rest of the nation. So it helps give say, hey, we have more opportunity here. Everybody's doing this. What are they doing? And how's their success been for this use case? Or we're super strong here. We are doing a really great job at staying with the national average, or even doing better than the national average. So it really highlights areas of opportunity as well as your strengths. And so all of this data actually goes in every month, and we're able to see averages by month for all the admission reasons, the discharge reasons, your interventions, your number of interventions, your number of stat alarm response times on average. So lots of nice, good data to help us keep your program functioning the best it can be. And
Yeah, because I'd love to see, especially with the stat alarm,
Yeah.
what times.
Yeah, so, I would love to have somebody in the department who would be the chief go-to on this stuff. So get one person to sign on, and then let you guys kind of distribute every month. Kind of take it out of my hands because it will be more
Yeah.
likely to be done.
Okay.
If you take it out of my hands, I'll be straight up honest about it. So that's kind
Like
of,
your
That's something we'll
honesty.
probably post in the group to see who wants to do it. then.
yeah, I'd like to have a champion is that what you usually see, Lindsay, like a champion in a department?
yeah, if you have the capability to do that, to have what some people do, what they call like a charge lead, or charge, almost like a charge nurse, but they're a charge tech, or they call them a lead tech. And if you have the ability to have somebody, they don't always even take an assignment, right? They're there to field the admissions, the discharges, get all the information, um, round on floors, get contact information. I don't know if you guys struggle with that at all, but obtaining who the new nurses are, who the new CNAs are, and getting all their phone numbers can be a challenge.
I was gonna say, Ashley's probably our newest member. She used to be she is a current PCT, my bad. She has done her best to like get like the ones we're familiar with, put their names down, but like that would help us so much if we had a
Right.
list of who
Right,
the
and-
nurses and CNAs are and stuff, because we're struggling all the time,
Yeah.
especially with all the travel nurses we've been getting.
Oh, yeah.
And so like a lot of times we'll call and they will only give us a first name. And it's like, that doesn't help us contact the nurse for this patient,
Yeah.
you know, and sometimes we kind of have to fight them on
We
it.
can't say
So
that name. but-
that'd be so helpful.
Yeah. Yeah, super helpful. And that can delay a safety event perhaps, right? Because you're
It
calling the
has.
wrong number, you're not getting in touch with somebody and you need somebody in the room. So that person can do that even before the shift ends. So they have all that information for who's oncoming. They can also help with that report piece. So, every shift, those nurses should be calling you to give report. Now, it's not going to be perfect, and it's every single hospital has this challenge to some point or some degree. Many of my hospitals that I talk to now will say if the nurse hasn't called you within an hour to give you updates, then go ahead and call them. Or if you see the nurse at the bedside in the room, hit that little microphone and just say, "Hey, it's Lindsay. I'm behind the camera today. I'm just seeing if there's any changes or updates." So you can get that report as well. But the lead tech can also do that type of thing, calling, touching base. Maybe they touch base at 5 instead of 8 p.m. when they're busy doing their assessments and just got all their reports. So maybe they touch base with the nurse at the end of the shift to get updates for the next shift. So that report's really important too. Some people, you guys being a standalone, have the ability to do what we call like a rounder rover role as well, where they have a tech who doesn't always take an assignment either. They'll cover for the breaks, but they also round on all of the patients who are on devices. Nurses are now seeing human beings' faces and seeing the staff that works behind those devices, and you're able to actually touch base, get a report, see if they need anything, help with troubleshooting of the devices, swapping devices in and out. So lots of different tasks that you can do for that. I have some, if this is really something you're interested in, Jimmy, some sites that have this all set up. They actually sent me their roles and responsibilities and their job descriptions too. Now, it doesn't always even have to be like a elevated or pay increase type thing. Sometimes it's just a lateral move, kind of like a charge nurse may be at some hospitals. But it's really nice if you have the ability to do that. Huge benefit for the program. And then they can do some of this data and analytics too. So you can monitor that and make sure that we're all performing the best that we possibly can. Super good questions, you guys. Privacy feature. Do you guys find that the staff calls you and asks for privacy?
About, maybe 60% of the time.
Just depends.
It depends. Some of them are good about calling us back and being like, hey, can you turn off privacy mode? A lot of
Yeah.
times we resort to having to listen to see if we're still in the room.
Yeah.
So,
Okay. Good for you though. You just said the one thing I would recommend doing. So sometimes, especially if you have a lot of travelers, they really don't even know about this feature.
Yeah.
If they've never seen AvaSure before, they don't even know that this is here. And all of a sudden you'll be watching and they're like getting them up to toilet them or, doing a
they'll
bath
put the
right in front of
camera.
you. Yes. Or they'll plop something over the camera. Very big safety issue. They should never be putting anything over the camera. Just, politely, gently remind them, hey, we have a privacy feature. It looks like you might need a little bit of privacy. How long would you like me to put the shield on for? Put the screen on for. So you can always like chime in and offer the
Yeah,
privacy.
that's usually what we do.
Yeah, and it's really nice, especially when family's at the bedside. I mean, listen, you guys are employees of the hospital. You're in a secure location. There's no visitors walking around behind you looking at the screen. You see this all the time, right? But it's really it's really for patient dignity. And it's really nice when there's loved ones at the bedside to hear you offer privacy when they're bathing a patient or something. So, just for those reasons, that's why this feature was created. So again, encouraging you to be proactive. If it looks like the caregiver's setting up for something, be proactive, offer some privacy, ask about how long they need, set your timer, your reminder if you want to. But if it's quiet, if you click into there, you're not hearing anything, it's been about 15 minutes, like they said, voice into the room, ask if they still need the privacy screen. If you don't hear anybody, then you're dropping that now, because now it's a safety issue. And they may have had to run out to another patient's room or something. So sounds like you're doing that already. The amber light. So there's always that orange amber glow light. That means that the video stream is live. It'll go off and you'll hear that chime when you put the privacy on and off. You probably
I didn't know
heard
it had a light that went with it, but we do hear the chime, yes.
okay.
There's a little orange one on the box.
Yep. So there's that
okay.
orange glow at the top that'll be on when it's working.
Okay.
Okay. The intervention log. So are you guys documenting? I know we've talked about a little bit of documenting, but are you actually documenting your adverse events that you've prevented?
On paper, we are.
Yeah, usually on paper. Now that we, now with the new update and all the new options we just got, I've
Yes.
used it.
Good.
I've used it, my last shift.
Okay. Good. And these are those adverse events prevented that I was mentioning. So every time you do an intervention, it goes up into the intervention log that looks like this. And it'll show you the time and what type of intervention you used and who the patient was. And each time that you press an intervention, they'll all go up here. The biggest thing is, I encourage you, after you prevent an adverse event, get in the habit of jumping up there and taking credit for that. So that way you don't forget about it. These will fall off the log. And I can't remember, Jimmy, but Jimmy and I looked at this and set the time frame for it. It's generally on average like 25 to 45 minutes on average. It'll
That's
fall
awesome.
off the log. I'm sorry, did you have a question?
We couldn't remember how long,
Oh.
but I'll go with what you say, 30
Yeah.
minutes.
I can't really remember. That's average. That's why I'm throwing that out there. Sometimes bigger hospitals monitoring, 16 patients pretty regularly will put it up a little bit higher, maybe closer to 60. But sometimes when you leave it at 60, then it's too long and you forget to go back and document or can't even remember what happened an hour ago. So I usually encourage closer to the, 20 to 30 minute time frame. Now, if I used 2 interventions on you, so you go to get out of bed, tell you to have a seat, you ignore me and stand up anyway. So then I press a stat alarm, nurse gets in there, get you to the bathroom safely, no fall happened. Now I'm going to go up into my intervention log and I'm going to document that I prevented a fall from happening. I'm actually only going to click one of those buttons though. So I used a stat alert and I used a verbal, but I only prevented one fall. So I'm going to just click stat alert and I'm going to click fall avoided and I'm going to chart that. That verbal intervention that I used will fall off the log in that 25 minutes. So don't worry, that will fall off the log. If you click both of those, the data can show 2 falls were avoided. So it's doubling your adverse events prevented. Okay. And then again, same thing here with other. Just use other if you need it. If you actually have a choice for it, try to actually choose the choice over using other. And this is just a slide that shows correct documentation that I was just mentioning. So I used multiple interventions, but I only stopped one adverse event from happening. So I'm just clicking one. Incorrect documentation is here on the right where I just went ahead and clicked all 4 of those. Now I'm charting 4 adverse events prevented. Same thing with your adverse event reporting. Now you may have been doing this on paper or in some sort of incident reporting. And if that's the way you're doing it, that's fine too. But there is an option in the software to document your adverse events as well. And that's usually like the bottom left-hand side of your software. And so this just walks you through how to go ahead and document that. The biggest thing here is do not use any patient identifiers. So no names, no birthdays, no medical record numbers. We really do not have any PHI in any of our data here. And the good thing is if you do this here, it can send an email directly to your manager. So we'll know that that adverse event happened and can look into it right then versus having to wait for that incident report to come out. You guys can be really proactive about it. Any questions on that?
Is that set up right now, Lindsay, to where if they put something in there, it'll send an email to us?
Yeah, we'll have to, I'm pretty sure we did that in your settings, but in your admin panel, so if you were to log into your dashboard, and if you go to the gear in the bottom left-hand corner of your screen, you'll see an envelope icon, and that's where you would have gone to sign up for it. I don't have access to see, so we'll have to walk through there.
Can we add more than one email to
Yep.
that or just one? Okay.
Nope, you can add whomever you'd like to that.
Okay, I'll take a look at that.
Okay, yeah, and just give me a call if you need help walking through there. If you just did a recent upgrade, didn't you?
Yes.
So it may have defaulted back. So that wouldn't be a bad idea to let's peek at your settings. And just make sure everything's still set up the way you want it.
Thank you.
Mm-hmm. All right, these next few are just a couple fun ones, a couple what would you do's in these situations. So you lost visual of one of your patients. What is the first thing you would do to maintain patient safety? And anybody can yell it out.
Call your nurse.
Yeah, you call your nurse.
You got it. Call your nurse. Now this, I always like to just jump on a soapbox here for a minute because I'm sure this happens to you all a lot, where they unplug the device from the wall.
Yep.
And then you lose video stream and you call them and they say, oh, I'm discharging them. Number one, they really should never unplug that unless they call you guys first. I really always encourage having your phone number right on every device, like with a label maker, boom, put your phone number right on there so they can see the phone
I
number.
know sometimes they have a hard time like knowing our extension, so.
Uh-huh.
Are they? Okay.
Sometimes
Are they on?
we're lucky if they call us at all.
Yeah,
We just
I
call
know.
them and say, did that person leave? I'll see transport in the room. I know they're leaving and I get on there and I say, oh, are they being discharged?
Oh,
Because
bless
I'm
your heart.
like, hey, call me.
Yep, because you have to know. And that's what you should do. Call them, right? I see your patient leaving. But yes, they should never unplug that. Some sites will put do not unplug without calling and then put the phone number there too. It'll still happen though. But you'll get on the phone and call, they'll tell you they're discharging. It's really important that you guys then do that discharge though in the software. Don't let it automatically discharge because those data pieces that I showed you, we'll lose a lot of that. We lose the discharge reason, we lose that you were doing the monitoring. So it's really important that you guys also do that discharge so it's not an automatic patient discharge from the software.
I'd say that rarely ever happens.
Yeah.
It's maybe happened
Good.
maybe twice in the last year, maybe.
Good. And you know, when they go out to a procedure, I'll just bring this up because I heard you mention that as well. You know, let's say they're leaving the room for a procedure, you can set your patient out of room. When they come back, it's not a bad idea to touch base with that nurse, right? What if they came back with a Penrose drain in their abdomen? Right? But they come back, they're in bed, they're just laying there comfy. You would have no idea they got a drain in their abdomen when they just went out of the room, you know, for those 3 or 4 hours.
Yeah, we
So-
usually.
Do you get that information?
No, we usually, sometimes some of the nurses are okay with it, but usually we have to call to find out what happened.
Yeah. Yeah. So good for you guys. It sounds like you're advocating for yourselves and touching base. It happens a lot. Then that particular patient I'm mentoring puts their hands under their blankets, which normally you wouldn't think twice about it, right? But if they had a Penrose in their abdomen, you're probably going to say, can you please remove your arms, right? Because you don't want them pulling that drain out. So happens, we do hear about that. But again, that's that communication piece that's so, so important. Basic troubleshooting of a technical issue has not resolved. You're still having trouble. Do you know who to call and where you can find the contact information?
Yeah, we have it
Sure.
right next to us. We call it
Perfect.
AvaSure, but
Awesome.
we have all that next to us. So.
Love it. Okay, and right in the software, there's a help button and our phone number will show up right under that help button too, if you ever can't find it. But yes, we are here 24/7. Doesn't matter the time of the day. If you guys can't resolve something quickly, please go ahead and contact AvaSure. You're monitoring a patient for a medical device interference, and several hours into your shift, you notice them walk over to the trash can, remove the trash can liner. You see them get back in bed, and now they place the bag over their head and pull up the covers, and you can no longer see them. What would you do? You got it. So press the stat alarm. We're not watching for suicide, but now we're concerned for that, right? So you're pressing that stat, you're calling that nurse, you're doing your documentation in the software. And I would imagine a conversation would need to happen with that nurse about their level of suicide risk now, right? Are we monitoring them for self-harm, or are they excluded, and do they need a one-to-one now?
Sometimes the patient's doing something, and then when the nurse gets in there, because, they'll jump back in their bed and cover
Oh,
up.
yes.
And then the nurse is coming in and looking around, and so I always get on there and I say, they were getting up, because
Oh,
I don't
yeah.
want her to think we're just crazy and hitting
No.
buttons.
Yep, that's what I would do too. I'd say, sorry, they were jumped up, but they got back in bed very quickly. Thank you, Mr. Smith, for popping back in bed, something like that. But yeah, that happens a lot. We actually had this one lady, she was being monitored for elopement, and she would go to her door and she'd step her foot out the door, and then the stat alarm would go off and she'd go jump in bed, and the nurse would come in and she'd be in bed. She did it over and over again. I think the tech finally had to call and just say, listen, this is what she's doing to me. But it happens all the time. They jump right back in bed when they hear that alarm go off. Okay, you're monitoring a 9-year-old patient with a broken arm for elopement. The parent is in the room with them, and you notice this sound bar indicator going from green to red, green to red. So you click to listen into the room. The young patient looks tearful, and you overhear the patient angrily saying to them, I hope you learned a lesson. Talk back to me like that again, and you're going to get a lot worse than a broken arm. I'm so tired of you and your smart mouth. What would you do?
Would call the nurse.
Call the nurse.
Good. Perfect.
Would it be security for that, or? I mean, I'd know if they would be like actively harming them, that'd be one thing, but.
Correct. I would agree with your response. I'd notify the assigned nurse and have a conversation about what you overheard, maybe alert security in the background. But the biggest thing, and why I'm happy you said that response, is that you wouldn't want to talk into the room, because that can escalate things. Certainly wouldn't want to press a stat alarm, right? So you want to do that phone call, not anything through the patient's room, and notify the appropriate parties. So super good answer. And that's why we ask this question. Just a couple more. At shift report, you learn you'll be monitoring a patient for substance withdrawal. You're told the patient is typically calm and soft-spoken, but shortly into your shift, you notice the patient get extremely excited when a visitor brings them a big gulp from 7-Eleven. As the visit progresses, you observe the patient becoming more animated and loud. The friend then shakes the patient's hand before leaving the room, and it looks to you like the patient quickly places their clenched hand under the sheet. What would you do?
Had this one before.
Call the nurse.
Yeah.
We've had this one before.
Yep.
We have, and usually the nurse will go in and shake out the sheets.
Yep. So biggest thing is we're calling that nurse. We're not doing anything through that room again as well, right? To escalate. We
Yeah.
just had one of these, a good catch the other day that came to us. Visitor had hidden a pill in the trim of the wall. There was a little piece of the trim that they were able to pop out, and apparently they were hiding pills in there. And the VSAs caught it. And stopped it from being ingested. So super good catch, but those visitors are creative.
Yeah, they try to hide stuff. I sent the nurse in because we were watching this lady and with her boyfriend or whatever, he was the patient. And, I saw her give him something and then he put it in his pocket.
Ugh.
Well, so I called the nurse. I thought it was, a vape or a knife or something, because it was small, and then it was a wooden cross. I felt so bad, but I
Oh.
didn't know.
Oh yeah.
Still, they need to look. It was just a little cross somebody had carved, and I'm like,
Oh, bless your heart.
sorry about
But you did the right thing.
It would have been my luck if I hadn't called. It would have been a knife. You're gonna stab somebody. It's like,
Absolutely. Oh, that's cute. We had another one. It was a significant other visiting their loved one. And I believe we're watching for substance withdrawal and went to give a kiss, but the VSA said the kiss just looked weird. And they came in and they were passing pills through kiss. Yes. And so follow your gut because it could be something like that.
yeah. I've
All
watched
right.
them take the vape, draw off the vape, put it under their bed, under their sheet. I'll call the nurse and I'm like, go into the room and look on the right side of him under his sheet.
Yeah. Oh
There it
my
is.
gosh.
Vodka one day, poured in the bathroom some vodka and brought it back and give it to him. It was like,
Oh my
Lovely.
gosh. Or the patients
did-
drinking their hand sanitizer, right?
We did have to watch one for that, didn't we? He was sucking on the wipes or something like that.
oh,
Yep.
I missed that one. That's gross. Ugh.
All right. So, you're monitoring a patient for falls. You have been frequently redirecting them to remain in bed, use the call light, and wait for assistance if they'd like to get out of bed. They move slowly, so you've been calling the nurse each time they try to get up, and you do not respond to your redirection. You sense the nurse becoming agitated with the frequency of the calls, and they tell you it's fine if they want to walk around by themselves. I'm not worried about it, so you shouldn't be either. What would you do?
Usually that's like a charge nurse. we
Yeah.
go to.
Yeah.
If the nurse is being like unreasonable like that.
Yep,
Especially if you're already watching them for falls, they're not gonna
Yeah.
let them just get up and walk around by themselves.
Yeah.
nailed it.
I wouldn't
Yes.
suggest like just charging them from the camera. I mean, they're gonna fall. I mean.
Yep, you got it. You guys are saying all the right things. So number one, are we still watching them for falls? Right? If you're not worried about them getting up, my primary reason for monitoring them is falls. I need to make sure that there is an employee within arm's reach so they don't fall. I can't allow them to get up. Would you like me to DC the monitor if they're no longer a fall risk? Right?
Yeah.
Or are you worried about them eloping perhaps? Is the reason we're monitoring no longer falls? Has it evolved into maybe elopement? I can change their primary reason for monitoring. So with your upgrade, remember, you guys can change the primary reason for monitoring. So if they're no longer a fall risk, inquire if they should maybe be elopement, right? Or maybe their behavior's improved and they no longer need this anymore. Because you're going to monitor for falls very differently than you monitor for a patient who can walk around their room. And if they're still being angry and not nice to you, then absolutely escalate that to a charge nurse or a nurse manager or your manager.
We don't mind to call the charge nurse. I don't. I'll call her right up. Tell her
Good
the whole
for you.
situation. This is my issue. How was that when you
Oh,
get that phone call?
yeah. Good for you guys. You sound like a great group. All right, this is the last one, promise. You're monitoring a patient for falls and medical device interference. They also have short-term memory loss and are very anxious. And you learn they do like to watch TV when they have no visitors. The news is reporting about a hurricane heading toward the coast several states away, but they're advising everybody in the area to evacuate immediately. You observe the patient becoming anxious and fearful. You voice in and ask if they're okay, and they shout back that it's coming our way. We have to evacuate. I need to get out of here. What would you do?
Have someone go change their channel.
Yay. Love
I
it.
was gonna say,
100%, you
wanna be
guys.
nice and try and calm them down too, Jean.
Yes, that's actually the 2 responses. So, yep, click into the room, reassure them that it's okay, and then call the nurse and have them just go ahead and change that station. So, awesome job, you guys. I'm gonna exit this so I can maybe see again here. Stop presenting. But any other questions or feedback from anything?
Was there anything, because I know we kind of asked around, I think that was pretty much it. You know, unless you guys have questions?
Do you have, Lindsay, this is Jimmy, when you talk about that great catch board,
Huh?
do you have, possibly like a template for that, or if we wanted to do that, do you have some kind of, like a one pager in guidance or something that other places have done well with it?
I just have a great catch log. It's not really a template or anything. The one that does the board, she just recently told me about it. It's called a kudos board. It's just a big whiteboard, and they just pop up on their break or at lunch and just jot down a couple good ones up on the board. So they just kind of have them scattered.
Okay.
But I do just have like a paper log. It's pretty simplistic though, and it's just a great catch log. So I'll send you that.
Okay.
Another one, the one that I was mentioning, she had a quarterly newsletter that she'd send out. It was an AvaSure quarterly newsletter, and over the quarter, she'd just jot down common things that came up. One was that people kept saying they don't know how to get a hold of the hub, so she told everybody, you know, what the phone number was. Did you know ABC? So anything that's problematic that month or that quarter, and then they always did a VSA spotlight and put a picture of a monitor tech and introduced them. So everybody kind of saw their faces and did a great catch in the newsletter. So I don't really have, I actually might have an example of her newsletter. I think she let me share that with somebody.
Yeah, that would be great if we could just see an
Okay.
example. We do have a patient safety committee. And
Uh-huh.
so I think that, and I'm pretty sure she does a monthly, if not quarterly newsletter. So I think that our data would go into that really nicely because then
That'd
it
be
gets
great.
distributed to everyone. So.
Yeah. Yep. And even if you guys are doing those interventions in the software, you have adverse events prevented that are documented in Orna. So there's a nice, pretty monthly metric that'll tell you how many happened each month. Just even the raw number.
Yeah.
So
Thank you.
super great job. Sounds like you got a lot of lead techs there.
Yes, we do.
I think that'd be an easy one to fill. I appreciate all the dialogue back and forth, you guys. If you ever have any questions, I mean, I'm happy to field them. Reach out to Jimmy, shoot them my way. I'm the clinical contact for your hospital for the life of the program. It's part of the program is to have us and our support. So we're here for you guys for whatever you need. But good work. Take credit for those good catches. They're deserving of others hearing about them. So. This program wouldn't be without you guys. So
Thank you, Lindsay. Thank you,
you're
Mary.
welcome. You guys have a great rest of your day.
All right.
Thank you.
Bye, everyone.